Afternoon, everyone, and thank you for joining us today for our webinar on Unhealthy FHOs equals Underperforming FITs. We have a great presentation for you today, giving you a high-level overview of some of the key concepts of working within the FHO and FIT models and what you can do to better support the FIT model within the FHO organization, and some best practices and tips and tricks, and a little bit about what we do here at Cirrus as well. So I do see that we have a number of new attendees today, which is fantastic. Thank you very much for taking the time to join us. So let's go ahead and get started. I will mention as well that we are recording the webinar, so if you have to leave or if one of your colleagues wants to see it, by all means you can send me a quick email, and at the end of the presentation I'm happy to send that over to you, and then of course answer any questions that you may have. So a little bit about Cirrus. As I said, we do have some new members today. Founded back in 1994, headquartered in Toronto, we provide business solutions to healthcare professionals across the province and across North America. We have two main components to our business: medical office lease negotiations, which were several hundred every year, well over 500, helping make sure that the lease that all these practitioners have that is in place is appropriate for them, and that they're safeguarded by from the landlords. And then the healthcare consulting side, which I'm part of, is billing support and operational guidance for both group and individual physicians. So we help, one physician, on a random street, wherever he or she may be, and we also work all the way up with large groups. So nothing too big, nothing too small that we're willing to and able to work with. So we help, as I said, we help optimize income, increase efficiency and flexibility. As I said, we work with FIGs, FHOs, FITs. Doctors who utilize our services do see quite a large increase in income, about 18%. And not only is it income, but it's also free time, flexibility, and a better understanding of what they need to do on a daily basis. And from a group perspective, at least one work week per month is saved by engaging with us. We have a large team here that is ready to support you and help you excuse me, with any concerns you may have with your group, or anything that we may be able to help with as it relates to billing and office flow and things like that. So if you do have any questions on that, please reach out. So what is the alignment between the FIT and the FHO? So over the years, we started, as you can see on the left there, in the fee-for-service model. Patients would come in, physicians would swipe the health card, they would get paid for each encounter that they have. As we went along, they created these models or groups and funding models that have transpired over the way. So family health groups, family health networks, family health organizations, obviously, all the way up to the family health team. We're increasing the interdisciplinary teams and improving patient care and outcomes. And that's the main goal that we're all here to watch for, is the patient outcomes. We want to make sure that we're able to provide the best and optimal patient care to our populations, and making sure that we're doing so in a manner where we have a balance, they have a balance, and everybody wins. So the FIT is built from the FHO model. So the FIT is a structure that works within, and the FHO is really what makes it run. If you don't have a properly functioning FHO, you're not going to have a properly functioning FIT. And we're going to talk a little bit about how to create a properly functioning FHO to utilize all the services that a FIT has to provide. So as we see here, FHO and FIT. So the FHO is actually just a billing model, and it's largely a fixed salary. So you have your capitation, you have your roster of patients that you're getting. Roughly 70, 75%, maybe even 80% of your income is coming from that. And you're providing a large range of services to your patients. You're providing access to your patients, making sure that they have same-day appointments available. If they call in the morning, on Monday mornings, as we're right now, and we want to make sure that they are able to come in and see you, not that they're getting an appointment at the end of the week or next week or the week after. We want to make sure that the access to care is available every single day. Increased levels of care for chronic patients. Again, if you're seeing patients that you don't need to see, you're taking that time away from those that do need to see you with those chronic conditions. So all those prescription renewals and so on, you don't need to see them on a regular basis. You can do that over the phone. You can do it through the pharmacy. You can just have them come in when it's medically necessary. And effectively implementing population-based screening practices. So making sure that you're aware of who your patient population are. Do you have a primarily older population? Do they need the vaccines? Do they need, other testing? Do they need, whatever it is that they do need? Making sure that you're aware of your population and making sure that you're treating them accordingly. Again, if, the flip side to that, if you have a lot of children, are they being immunized? Or, what's your program to make sure that they are immunized? Making sure that you're not missing any of them to make sure that you get your bonus. Now, if we flip over to the FIT side, the FIT is actually an operational model. So you need a FHO in order to be in a FIT. So you're placing the physicians in an environment designed to be highly collaborative. We want to make sure that everyone is working together. And again, if you're thinking in that fee-for-service mindset where you're seeing as many patients as you possibly can throughout the day, that doesn't allow for a collaborative environment. That doesn't allow for physicians to speak to one another and say, hey, I saw a patient this morning for A, B, and C, and, I was thinking about this, but, what about that? And you want to make sure that they have that opportunity to discuss with one another because someone may have seen something similar, not too long ago. And that allows for better care to your patients, allows, as we said, a collaborative approach to medicine. Providing groups funding. So again, if you hit certain targets, you're going to get more funding. Again, throwing that back to the physicians, it gives them the freedom, the flexibility, and to know that they're doing what they need to do in order to keep their patients healthy, and they're being rewarded and paid appropriately for it. The long-term target of an operating model to deliver primary care to Ontarians. We want to make sure that the FIT is around because as patients, we want to make sure that our doctors are being supported the best they can. And I know there's a lot of issues going around now with the negotiations and whatnot, but we want to make sure that these FIT models are around because it provides the collaborative care, it provides the comprehensive care, and it ultimately gives the patients a better experience and better outcome. So physician income and flexibility. Now, from a physician income standpoint, as I said earlier, in the FHO, 70 to 80% of your income is fixed based on your roster size. We want to look at increased income and premiums paid based on practice style. So all those special premiums that are available to you, all the preventive care bonuses that are available to you, making sure that you understand who your patient population is, making sure you understand how you would like to run your practice in order to maximize all those premiums and bonuses. And we're not so much focused anymore on the throughput, but rather the access to the patients. Rather, have those patients being able to call in or walk in and have same-day appointments and not just, a week, 2 weeks, 3 weeks out in some cases. Physician flexibility. We want to give them the ability to have a life outside of the office. Back in the fee-for-service world, they were working 12 hours a day, 7 days a week. We don't want that anymore. We want our physicians to be well-trained and well-compensated and have a life and a work-life balance. It provides them with a better outlook and a better ability to treat us. As we said, collaboration between colleagues within the group, very important. Not every doctor can see every single thing that comes around, and if you're able to collaborate and speak to one another, it gives you and the patients a better outcome and better possibilities. And the capability to effectively delegate to fit staff members. You have to be able to utilize your staff and make sure that people are there to help you, whether it's the physiotherapist, whether it's the nurses, whether it's the executive team. There's a bigger team involved, and you have to make sure that you're effectively delegating to those that need to do their job properly. So a little bit more, some key concepts in the billing model. So providing continuity of care to your patients, very important. Concentrating on chronic disease management and preventive care. Again, we don't want those patients that are healthy coming into the office just for a prescription renewal. We want to bring those that are chronically ill that need to be seen when they need to be seen. Increased collaboration, mentioned that a few times. Increase access to care for your patients within your community through same-day access and shared on-call obligations. Educating the patients, letting them know that they have the ability to come in and see their physician or another physician within the group same day. and letting them know that there's the after hours as well. So maybe they're not going to see their physician on this particular day, but going back to the continuity of care point at the beginning, if they see someone else in the office, that continuity of care is still there because that physician is then giving a report back to their family physician to let them know what has happened. If they go to the walk-in clinic, nobody knows what's happening. Chances are they're going to have to rerun tests, or God forbid one doctor prescribes one medication and one prescribes something else and they counteract, and it's bad news. So you want to have education to your patients to let them know what's available to them. Greater flexibility for physicians, allowing them to adjust their schedules. Again, we're all human. We have families. We have other obligations outside of work. We want to make sure that they have the ability to take care of those things, coming and going as they need, being able to see the patients that they need to see when they need to see them. It's a very, very big influence is a work-life balance and making sure that the physicians stay happy. Designed to align income and desired physician behavior. Again, every physician is going to be different. I get the question all the time, what are my colleagues doing or what are my counterparts doing that I should be doing? And the answer is nothing, because you need to do what you need to do, and every single physician is going to be different. So a little bit more about FHO income streams, 6 major income streams. We'll go through each one of them. Capitation payments, as I said earlier, is the strongest generator of income within the FHO model, averaging about $200 per patient per year as a prepayment for 126 fee codes that are considered in basket. And from our data, almost all patients are more valuable on the roster than off. There obviously are exceptions, and we go through that through the presentation, but generally speaking, most patients are more valuable on the roster. The financial impact of a roster, as you can see, 800 patients, 160,000 of guaranteed income, all the way up to 2,500 patients, 500,000 of guaranteed income. We want to make sure that you're aligning yourself with the goal of providing the preventive care and rather than reactive care. If you have 2,500 patients that you can't manage, you're not doing your job properly. But the flip side to that is if you only have 800 patients and you have a lot of free time on your hands, go ahead, roster some more patients. You have to find the right balance between a large roster and income that fits your needs. Again, no two physicians are alike. There's not going to be anyone that says, oh, I have X number of patients, you should have X number of patients. No, you have to have the right number of patients for you. Payments are made irrespective of number of total visits. So as I said, patients are more valuable on the roster than not because you're getting paid whether you see that patient or not. So if it's a high-use patient, okay, maybe we're gonna look at them to see if maybe they should come off the roster. But generally speaking, we want to see those patients rostered. Fee-for-service billings. Now, some of the out-of-basket areas that we want to look at. So when we say fee-for-service, we mean non-rostered patients that are being billed and getting paid full value, and then rostered patients that you're seeing for some of the out-of-basket or the more common chronic conditions, such as diabetes, smoking, after hours. Those are all out-of-basket, and you want to get paid the full value. So it's important to look and see what you want to do what you're doing on a daily basis to make sure that you're maximizing your income and maximizing your potential. Because if you're not billing your patients properly, if you're seeing a diabetic and billing an A7, there's a problem there. So we can help you to look and determine who your patients are, what you're doing for them, and if there's anything that you could be doing differently to earn income appropriately to what you're providing the care in. Your access bonus. Now, this is a funny one. Some areas you're going to get an access bonus, some areas you're not. It really is, it's becoming a lot more of a cultural aspect, and certain areas of the city, of the province, you're going to be able to capture your access bonus because to them, loyalty is very important, and they want to come and see you, and they don't want to go anywhere else, where the other parts of the city and the province, they're going to go anywhere and everywhere just because it's more convenient. If you work in downtown Toronto and your family physician is up in Markham or Unionville or wherever it is, you're not going to go to them if you have a sniffle or if you have something throughout the day. You're going to go to the walk-in clinic that's right downstairs from your office. For the bigger things, yes, you're going to go back to your family physician. But That's why it's become a little bit more difficult, but it is manageable, and that's something that we work with our physicians on a regular basis to make sure that they do maximize their potential with regards to their access bonus. So it's broken up into 2 time periods, April to September, October to March. Give or take $50,000 on average for an average physician throughout the whole year. We want to make sure that not only are individual physicians doing well, but groups are doing well, because it's paid out on a group based on group performance. And those that are negative do impact those that are positive. So it's all about the team spirit, all about making sure that every single physician in the group is willing to participate and willing to contribute their time and efforts in order to keep their access bonus positive. So some of the tips that we have for managing outside use is taking preventative action, educating your patients, not once, not twice, not 3 times, but every single time they come to the office. Have posters up, have business cards, have signs in the waiting room, in the exam rooms. Let the front staff tell the patients, even the physicians can tell the patients, that they have to come to see the doctors within the office. It goes back to the continuity of care. If they go elsewhere, nobody knows what's happening, and they want to make sure that they stay within the office. Be prepared to react. So you have to analyze the data. You have to analyze the data over a period of time. You can't look 1 month here, 1 month there, because it's patterns and trends that you need to look for. You have to focus on those red flags, those high contributors to outside use, the counseling, the sports medicine, the addiction, diet clinics in some cases. You want to make sure that you're looking at the patterns and trends at least over a 6-month period. And that's something that we stress heavily on our outside use reports. And keeping an ongoing watch. As I said, it's not going to be a one and done type deal. When you look at it 1 month, you see what's going on, and then you forget about it. This needs to be looked at month after month, and you need to look at these patients on a regular basis to see what's going on. And you have to convince them to change their behaviors. And if they're not willing to change their behaviors, then maybe they're not a patient for you to have on your roster. Maybe they're not a patient for you to have in your clinic, and that's something that we can help with as well. So 2 snippets from our outside use management analysis. What codes are being utilized? So we break it down in a pie chart to see what codes are being utilized outside of your clinic. A7 will always be the highest. That's a standard walk-in activity. And what days of the week are contributing to your highest outside use? So, if you're off on Tuesdays and your outside use is high on that day, makes sense. But if you're off on Tuesdays and your outside use is high on Mondays and Wednesdays, then we need to try and figure out what's going on there, and our analysis will help with that. Here we provide a list of your top 20 patients that are contributing to outside use. We break it down and by net position, and anyone greater than 100% on the return column all the way on the far right is not earning you anything you're not earning anything by having them on the roster, and it's time to get rid of them. Again, not necessarily from the practice, but from the roster. So let's talk now about some premiums and bonuses, preventive care bonuses and special premiums. $12,800 available annually for preventive care. Typical physician gets around $8,000. And in special premiums, we have $37,000 available annually. Typical physician in the 2 to 4 range. We do have quite a few that are higher now, and as we work with them, they get higher and higher. But this is typically what we see when they start working with us. It's a reward for broadening the scope of practice and the provisions of preventative care. Again, the more you do, the more you get paid. And the more you're doing, we want to make sure that you're getting paid, because if you're providing the care and not getting paid for it, that doesn't make much sense. So a little bit about FHO billing model summary. So roster management, ensuring that the patients who physicians are seeing are on the roster. A roster reconciliation at least once a year is extremely important. Comparing your ministry roster versus your EMR roster or your computer roster, whatever you have, very important. We do that with all of our clients. In the fee-for-service world, billings, ensure the physicians know the more common out-of-basket codes. Again, making sure that they're getting paid full value for those codes as well. Focusing on your diabetics, your smokers, your after-hours billing, any other type of care that you're providing, we'll be able to analyze the data within your billing software, within your RAs, to show you what you're doing on a regular basis and show you how you can do a little bit better. Outside use, again, you have to look at the data over a long period of time, making sure that you have the right patients rostered, looking at the patterns and trends, and figuring out does it make sense to keep the patients rostered or not? And with regards to special premiums and bonuses, ensure that the physicians are receiving payment for the services they're providing. If they're doing home visits, making sure that they're billing for home visits. If they're providing prenatal care, making sure that they're billing for prenatal care. And tracking your Prev care and special premiums throughout the year. Again, all the tracking codes for your PAPs, your MAMs, your colorectal screening, all that kind of stuff, for your bipolar patients, making sure that you're billing the right codes at the right times. So some of the common challenges in the FIT. Ministry targets not being met, especially roster targets. Now this is a problem for a lot of places now where because the unattached patient population is shrinking. There's more and more physicians. There's not that many unattached patients anymore in certain areas. And it's becoming harder and harder to meet those roster targets, not only for the FITs, but for the FHOs, for physicians who used to be on income stabilization and got kicked off, or who are now joining the new graduate entry program and not being able to meet those targets. It's becoming more and more difficult. High outside use across the board. Again, it's a group-based performance, so you have to make sure that everyone is on board, everyone is committed to doing what they need to do in order to maximize their access bonus and capture as much as they possibly can. No, you're not delegating, you're not working, you're not collaborating, as I said earlier, with one another. Speak to one another. Use the services that you have at your fingertips, the nurses, the executive teams, the admins. Everyone has their role, everyone has their part, everyone can help one another to achieve the greater good. And not understanding the FHO billing model. Again, we've seen time and time again physicians come to us who have even been practicing for a number of years who don't understand clearly and purely what to do in the FHO model, how to bill properly. They're still in that fee-for-service mindset. And for new graduates, this is extremely important because we need them to get started on the right foot. We don't want them to get confused or do things incorrectly from the start. We want them to be set on the right foot, on the right path, to make sure that they're maximizing their income from day one, making sure that they're providing optimal patient care from day one. And the lack of communication. Again, speak to one another. You have those resources, utilize them. And the lack of commitment. If the FIT, the general executive or the staff don't have the buy-in, don't have the commitment level, it's never going to work. You need everyone to be on the same page. And the missing FHO aspects. Again, physicians not willing to roster in areas where they're able to, and lacking the understanding of the FHO income breakdown, unclear of how to effectively manage outside use. We're here to help with that. You have to pay close attention month over month. Focus on fee-for-service mindset instead of shifting to the FHO spirit. Again, it's no longer a solo sport. It's a team sport now. Everyone is working together. And governance is not sufficient for the current issues within the FHO. A governance agreement is extremely important to know what the rules and regulations are within your group and making sure that everyone is following them. So how do we leverage the FHO model to function more effectively as a FIT? We create an effective organizational infrastructure, including strong governance, regular board and group meetings, and forums for discussions. I'm going to say this again, and I'll probably again and again. Communication is extremely important. Everyone needs to work with one another for the greater good. Everyone needs to support one another. Whether you're up at the top or down at the bottom, everyone needs to work together. Making sure that there's defined roles, making sure that people know what they need to do. And again, the communication. Develop an understanding of the FHO model, making sure that all the physicians understand that they're in a FHO, they're not working fee-for-service anymore, that they have to be more cognizant of the fact that patients have to come see them when they have to come see them in most cases, and not having patients that don't need to come see them. Prescription renewals, things like that, something that nurses can do over the phone, something that the doctors can do over the phone or via email or through the pharmacy, whatever the case may be. If those patients don't need to come into the office, don't have them come into the office. Implementing tools, again, using our outside use management analysis. All these little components and services and team building exercises, all those have a huge role. Effective roster management, all these things that play, most people are going to think, oh, it's just a little part of it. It's not. All those things add up. They build into the bigger picture. Ensuring physicians are educated as to how they're being paid. Again, it's very important that physicians know how they're being paid. I find way too many times where I speak to a physician and I say, when's the last time you looked at your RA? And they look at me with a blank stare and say never. You know, it's extremely, that's your pay stub. Most people who are working and they get paid, they look at their pay stub to make sure that it's correct. There's obviously not a lot on there, but there can be, and for a physician, the RA is their pay stub, and they need to look and make sure that they're being paid appropriately. If things aren't being billed, if things aren't being properly paid for, you have to look at your errors. You have to look at all those components to make sure, and that's something that we do on a regular basis with our physicians. Reach outside groups for help. Exactly like a consulting group. You have to make sure that you utilize the services available to you. You want to get started on the right track and maintain the course, and we're here to help with that. So ensuring that physicians understand both the FHO model and how to optimize their practice in the FIT, very important. Make the transition from focusing on throughput to providing access to care to the overall roster. Decrease medically unnecessary visits. I've said this again. The prescription renewals, physicals for otherwise healthy patients. Things could be handled over the phone. Increase access to care by keeping those same-day spots open. And again, alternately accessible. Maybe some emails, maybe some phone calls, whatever works for you. But find something else that works, because you don't want to bring those patients in if they don't need to come in. Managing outside use. Again, you have to look at this on a regular basis, making sure that you're looking at the physicians that are not negatively affecting the other physicians in the group. It's a group-wide initiative, a group sport, not a solo sport anymore. Tracking claim premiums and bonuses available to physicians for work they already provide. Very important. So some of the resources and tools that we use here. So our approach, we analyze, we educate, we set goals, and we optimize. So we'll sit down with our physicians, we'll sit down with our groups, we'll sit down with the FITs and the executives and whoever is the decision maker or whoever needs to be involved, and we're going to analyze the data. We're going to look to see what you're currently doing. We're going to educate you on the areas that we think are a little bit lacking. We're going to set new goals. We're going to make sure that we know exactly what we want to achieve, and we're going to optimize. We're going to make sure that you reach those goals and you become more profitable, more efficient, and overall just a better running office. Roster management, very important. Roster reconciliations, you have to know where you're able to get patients. Again, third-party consultants, you appropriately plan and align FIT goals with FHO realities. Educating staff and physicians on billing and scheduling best practices to increase FIT performance. Teaching physicians how to better leverage their allied health professionals and their teammates, so to speak. Best practices for integrating physicians to HealthLink within the community. Utilizing outside services, very important. Some of the tools that we use, as we've spoken about, we have RA summaries, making sure that people are aware of how they're earning money, where they're earning money from. Outside use management analyses, looking at your patients' patterns and trends. And roster reconciliations, roster optimization. We want to make sure that the patients that you believe to be rostered are in fact rostered. Some of the key takeaways from an educational standpoint: ensure that you are aware of the FHO program fundamentals in order to understand the physician point of view. Again, it's all about education, not only of the physicians, but of the staff and the patients as well. Communication. You have to speak to one another. You have to have regular meetings within the FHO and the FIT to ensure that the goals and responsibilities are aligned and that they're being met. Ensure the roles and responsibilities are appropriately delegated to meet the new goals. Making sure that people know what they need to do when they need to do it. And again, communication. Planning. Determine an annual FIT plan that has FHO buy-in. Making sure that everyone from the ground up is buying into this plan and making sure that everyone is committed to making sure that everything is done appropriately. And review. Review the common struggles within your FHO and FIT and determine the best way to improve outcomes. Is it education? Is it third-party neutral consultants? Is it reallocation of tasks? What are the issues? We're more than happy to help you figure out what the issues are and help you figure out how to fix them. So that brings us to the end of our presentation for today. I thank you very much for joining me and taking time out of your busy schedules. As I said, we are recording, so if anyone does need a copy for someone else or just to review, I'm more than happy to send that to you. My contact details are right there on the screen. You can email me, you can give me a call, and I'm happy to set up a meeting to discuss with you in a little bit more detail, whether it's on the bigger picture or the smaller picture as an individual physician. No problem. We're happy to come and meet with you and speak with you. So with that, I thank you very much for your time and hope you have a wonderful rest of the day.